Good afternoon, everybody, or good morning, depending on where you are. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar by C3 Healthcare RX called Expanding Behavioral Health Solutions for ACOs. A few items of note, housekeeping stuff before we get started here. All attendees have joined the webinar today in listen-only mode, so you're already muted, so you don't need to worry about muting your mic. Also, I'd like to inform you all that the webinar is being recorded, so you'll have the opportunity to rewatch the session and or share it with colleagues. And a link to the recording should be emailed to you following the presentation, but it'll also be available on the ACO Exhibit Hall website. And at the end of the presentation, I'll show you how to access that. Finally, during the webinar, you will be able to submit questions to our presenters at any time. Using your attendee control panel, and we will be able to answer as many of those as possible during the Q&A session at the end. For those questions we are not able to get to today, we'll follow up via email and answer them afterwards. All right, well, without further ado, I'd like to introduce our presenters today, Mr. Justin Mason, the Chief Product Development Officer, and also Lindy Kitchen, Lead Behavioral Health Manager, both with C3 Healthcare RX. Welcome to you both.
Thank you. Good morning.
Good morning.
All right. Well, I will get started. And again, thank you, Garrett, for having us. And we're really happy to be here today and to talk about expanding behavioral health solutions, particularly for ACOs, and how that's done kind of differently through the program that we have. And just a little bit about me. So I am, as Garrett mentioned, the Chief Product Development Officer for C3 Healthcare RX. I've been in healthcare for about the past 10 years. I've worked primarily with some pretty large companies that do chronic care management for at-risk populations. And so I've worked a lot under value-based payment models and primarily with interdisciplinary care teams to improve care for patients. So one of the original founders of Mind Healthy, which is owned by C3 Healthcare RX now. C3 Healthcare RX is a leading provider of in-home pharmacy and medication management. And I've been Chief Product Development Officer about the past year with this company, managing primarily the Mind Healthy product.
My name's Lindy Kitchen. I'm a licensed clinical social worker, and I have over 10 years experience in mental health and addiction counseling in both private practice, psychiatric services. I've also worked in large hospitals, health departments, and had, a variety of different experience with case management, care management throughout different populations within the healthcare system. And so I'm excited to be here and share more about my lead role with the care manager with C3.
All right, so I will just do a quick rundown of what we're going to cover today. We'll do an overview of this space and this industry and mental health as it applies to an ACO, how our model applies to that as well, and then some of the outcomes that have been achieved through what we can provide. And we'll wrap it up with questions, and we're looking forward to that. And, so at a high level, some of the topics that we're going to cover, or key topics, are really how we increase mental health access and psychiatry services in the primary care space and in the ACO space. So theme you'll hear from us is identification and engagement. Those are really the two key goals and drivers of what we do. And what has been evidence-based to show to provide the right level of care and make impact on mental health issues. So with that said, we're going to talk about our way of screening and providing mental health resources to assess patients on a regular basis. And then we'll talk a bit about the evidence-based approach that we utilize and some of the outcomes that are driven through that. And then really tie it all back to how this applies to an ACO at a population level and the impacts that can be driven there. And then the last piece to this, so what we're talking about is not really a new program. There's a lot of evidence-based research on it, but what is new is CMS and most commercial payers reimbursement directly to a PCP for applying this program in their practice. And so we'll talk about that. All right, and if I'll just do a quick dive in about Mind Healthy's integrated behavioral health program. So the goal of our program is really to provide psychiatric, social worker, case management support, but to still keep the PCP as the quarterback of the care. There are, billions of patients, particularly Medicare and Medicaid, with mental health conditions. We'll talk about that a bit more. And there's been some really good evidence-based approaches to meeting that care that have been studied over the past couple of decades. The model that we're talking about today that we utilize has over 80 controlled trials that have been done and shown to be effective for diabetes, depression, anxiety, and then many other more severe mental illnesses as well, and across the demographics. Last point that I would point out here, the goal of the program really is to treat episodically patients. So if someone has depression, for example, that they would start the program, but the goal is to get them to a stabilized point and for them to graduate off the program. And typically that takes about 6 to 10 months. And if I am an ACO, I want to discuss quality measures in this conversation as well. And I did want to highlight some of the quality measures that are impacted by this integrated behavioral health approach that we utilize. And so if you're an ACO, you're definitely familiar with meaningful measures. And of the 6 meaningful measures, mental health and behavioral health under our model impacts about 4 of those. I'll just touch on a couple of those. So strengthening engagement, we're going to talk a bit more about how we engage patients differently than you would in a traditional referral model. And it's telephonic, televideo, and then app-based care, which we'll talk a bit more. Coordination of care, we also impact through how we document and work with the PCP in a collaborative approach versus a referral approach, and then a registry that we utilize, which impacts and improves that. And then this last one, which I'll really focus on a bit more, is the prevention and treatment of chronic disease. Under that one, there are 2 subsets that directly are mentioned. One is impact and management of depression and impact and management of substance abuse, both of which this model impacts directly, and just at a much lower cost than in a traditional basis. All right. And I think a really good place for me to start as we talk about this is to start with what mental health looks like today, specifically for an ACO population. And so we know that 9% of Medicare patients have a mental health diagnosis. About 14% of Medicaid population has a mental health diagnosis. And those with mental health plus a chronic illness on average cost more than 1.5 times more than a patient with just chronic disease or chronic illness alone. And you'll see that number highlighted there. It's about 38,000 versus 22,000 on an annual basis. So there's a 16,000 differential on an annual basis per member with a mental health diagnosis. And so let's take a look if an ACO has 10 patients with a mental health diagnosis, how they would be treated under today's model. So there are really 2 options. The first option is refer. And so you refer out to a psychiatrist or another mental health professional. The second option is for the primary care physician to manage the patient directly, and that would be medication management. And so we'll talk a bit about how that looks. So under this first one, if you make a referral out to a psychiatrist or behavioral health professional, about 1 in 10 patients actually are referred. And those that are referred have about a 50-50 chance of actually going to that first appointment. Those that do make it to that first appointment, on average, have a mean number of 2 visits before they drop out of the program. And let's look at the second approach. The second approach is using a primary care physician. And so about 2 out of those 10 patients are managed by a PCP today. And so there are about 30 million patients right now that have a prescription for mental health diagnosis and to treat a mental health illness. Less than 25% of those have been shown to improve under that kind of PCP management and medication management. It's to no fault of the PCP. It's just they're not structured and built to manage behavioral health on a comprehensive scale. And just the medication management is not impactful enough alone. And so who's actually receiving effective care? If you take a look at this, 7 out of the 10 patients receive no care at all. The one that is under PCP management that is improving is positive, but there's another one that is not receiving any improvement. And then 1 out of 10 is receiving that ongoing psychiatric collaborative care. So you've got about 80% of your total population that's receiving no care, no impact to care at all. And we've talked to a lot of ACOs, and some of the things we hear on a really regular basis are, hey, we're impacting mental health and we're addressing patient care, and we think we've got a good system in place. And quite often we just ask the ACO to go back and just take a second look at it. And if we go to the next slide, we'll dive into some reasons why we ask that. We know that there is a shortage across the nation of psychiatrists and mental health providers. If we take a look at this map, this is a heat map of the United States, and the bright yellow is the highest rank in terms of access to mental health professionals, and the dark green is the lowest ranking. And you can see about 75% of the country is struggling in terms of access to mental health care. And what I mean by that is, mental health workforce availability. So there's a shortage of psychiatrists, which leads to, either very long wait times for patients or just very limited access. So there are psychiatrists that do not accept even commercial insurance, and very few that accept Medicaid or Medicare. And so this just leads to a very large barrier for patients. And so again, to no fault to an ACO or a PCP, but there's just not enough resources for them to refer out to get effective care for their patients. And so I'd like to just take a moment and talk about how we're addressing this problem a bit differently, and the collaborative care approach that we utilize when working with a primary care physician. So there are really 4 key components. The first component is a psychiatrist, and so our psychiatrists are utilized really as a consultant to the PCP, and so they provide medication management consultation, but the PCP still remains the prescriber in this scenario. In addition, we add a behavioral health care manager, which is often a social worker, and that person really fills in the gap in between care and make sure everyone is able to work efficiently and at the top of their license. So think a patient that has a new prescription for a medication, and that medication is not quite working the way it's supposed to. And typically a patient might try to go back to their PCP or psychiatrist, and that could take weeks, and often patients just give up and they stop. Adding that layer of that care manager provides someone that does a telephonic follow-up and reaches out to the patient directly and really advocates and keeps them in the program, and they're kind of coordinating across this care spectrum. The last piece that's required per CMS for a PCP to reimburse for this program is this registry. And so Vitality provides a registry that's also a complete platform that includes mental health assessments, which we'll talk about a little bit further, but that's another key component. And I'm going to stop at this point and turn it over to Lindy. We'll talk a little bit more about how we implement.
Okay, let's talk a little bit about the different roles from that previous diagram. The first role, of course, is the PCP or the practitioner. And this model of integrated care is keeping that practitioner at the forefront as the quarterback of that patient's care. Most patients are linked to a medical home and identified as a high-risk patient through some of the screening tools like the PHQ-9 and other tools that are being utilized by this program. And so once patients are identified, the primary care has 2 options: to start and prescribe pharmacological treatments, and that's usually where the treatment stops for practitioners, and that is where integrated care and a program like this are going to change that, and we are changing that. And so we're able to provide our next slide, which is the role of the behavioral care manager, a direct referral from the PCP office for patients that are screened as high risk or diagnosed with a behavioral health disorder, into the role with the behavioral care manager. That is my role as the lead care manager with C3, and some of the role that I play is first off connecting with patients as they are referred from physicians. The care manager supports all the delivery and coordinates and collaborates care between all the providers. We administer validated mental health comprehensive clinical assessments via telephonic or televideo outreach, whichever a patient prefers. And, developing an initial care plan and consulting with our psychiatric consultants within the program. Oftentimes, some of the things that we see as care managers is when PCPs start a new medication, especially the antidepressants that are very common to treat patients with depression and sometimes anxiety disorders. Those medications can take quite a bit of time to become effective, and so there can be anywhere from a 4 to 8 week period. And so that's one of the things that we provide education and support and consultation with our psychiatric consult in order for patients to not give up so quickly if they feel that the effectiveness is not quite there as quickly as they would like. We monitor patients' progress. We report that in the registry so that outcomes can be tracked, and hopefully patients see improvement over the 6 to 10 month span of being provided care management type services. We often revise care plans for patients that are not responding and help practitioners know a little bit more quickly if a patient is responding to a particular therapy rather than waiting the typical 3 to 4 month follow-up that often primary care providers, it's all that they can do to see a patient within that amount of time. And so also the care manager is responsible for maintaining the relationship with the patients. It's an ongoing relationship and a collaborative approach to help, the practitioner, psych consult, and any part of the family system that may be causing stress for the patient in order to be able to provide care and implement that treatment plan. So the other role that we have is the psychiatric consultant. And this is a very important role because primary care providers almost have to play a dual role within the medical community of psychiatrists and managing physical health conditions. And for many years, those have been sort of separated, and now the integrated approach is helping link the mind-body connection. So they are there to develop patient care plans for both medication and behavioral intervention in support with the care manager aspect. They can advise the practitioner and care manager regarding a diagnosis, also make recommendations for resolving some of the patient adherence intolerance issues that we often see with some of the care management services that we provide weekly to patients. And also one of the big things are negative interactions. Psychotropic medications oftentimes come with side effects, and that is where care management and having another consultant role that can reach out both telephonically or via televideo can help create a comfort level and education for patients in order to increase compliance and have effectiveness with treatments. And so the other role is participating in a regular clinical review of patients within the program, and that usually happens weekly. And so care managers and the psychiatric consultant coordinate the care and decide what relevant information is necessary to report back to the PCP or medical home so that the care remains integrated and it creates the team approach that we're looking for. So the clinical workflow, how this all really plays out, it starts with the care manager, the psychiatric consultant, developing a good relationship with the practitioner and the office staff. In-service training is provided to educate and introduce the teams and build relationships so that referrals can be made more easily throughout, all the interaction that patients receive within their medical home. Screening is very important to identify high-risk patients with standardized screening tools. Once patients are screened, they have a consent and enrollment happens for eligible patients. And the engagement process is really where the care manager comes in and, does a telephonic outreach in order to help patients learn more about care management and psychiatric consultant services. So I'd like at this time to give you sort of a real life example of what it's like for a patient to begin in this program and some of the needs that can be met. So one example is a particular patient that I've recently worked on, and the referral was made from the primary care, and there was a high-risk screening for depression and anxiety. And upon outreach and engaging with the patient, I found as the care manager that this particular patient had suffered a physical disability, post-military duty, and had already received extensive psychiatric and psychotherapy services within their community in conjunction with referrals from primary care. But yet, after extensive treatment for those mental health issues, that person had addressed a lot of trauma and other things that had gone on in the past, but were still suffering with depression, because we all know that sometimes mental health is an ongoing diagnosis, that there's no beginning and end date sometimes to treatment. So this particular patient was very engaged and interested in the care management services from the aspect of focusing on where their present needs were, with understanding what kind of possible work they could do through the vocational rehab program in their area, and linkage to other types of case management services that would help them with financial stability, housing stability, and other types of issues just to meet basic needs or survival that can often drive, depression scores to be really high when people don't have basic needs met, as well as, medical complications and side effects that needed to be worked with our psychiatric consultants. So that's sort of, a way that on a weekly or biweekly basis, a care manager can identify from referrals from practices, engage the patient, clarify any diagnosis, initiate treatment, and create a follow-up care system throughout, a 2 to 10, 12-month period, and make some progress with some of the areas that people are struggling with that a primary care provider is never going to have that time to do outside of the medication assistance treatment that they're providing. So that's just sort of a good example and a summary of how this program plays out with real patients in real life.
All right, and I think that was just a really great example of how we use the different levels of care to meet the right need for the patient. And we talked at a very high level about the registry, which is a necessary component of the reimbursement for this type of care. And I just wanted to talk about that a bit further. So each patient does a mental health assessment, either via tablet or hard copy inside the PCP's office. And we track each one of those results on the mental health scores on an ongoing basis, and it's re-administered every 30 days so that we can really track over time patient results. This registry allows us to be able to do that, and not only just to track ongoing results, but really be able to risk stratify your patients in a very real-time basis and see from a population level where your patients are struggling the most. And as I talked about kind of that ongoing assessment, we utilize a measurement-based approach to improving care. So it's really outcomes driven, and you have results and documentation to back up those outcomes. And so, for example, a patient that might start off with a PHQ score of 20 and is moderately severe depressed, the goal may be to get them to a PHQ-9 score of 10 or less. And we reassess each month so that we have, a quantitative assessment that we can point to, in addition to the qualitative assessment that the care manager and psychiatrists are recording for the patient. And Lindy already covered how there's just a range of treatments that can be provided, from the medication management to therapy to kind of resource coordination and case management. All right, now as we talked about outcomes for the program, I'm going to just refer to one of the studies that discusses a reduction in time. This one is specifically for depression, but there are studies across depression, anxiety, quite a few other mental health conditions that show a reduction in time required to actually show a response to treatment. And typically that time has been cut in about half from the traditional model of a referral. As an ACO, I'd like to share just a couple more high-level outcomes as well. And so we talked about that reduction in time, which translates into less medical spend and less time, treating a patient, increases patient satisfaction. And so these are some of the other reported measures from studies previously. So 82% of patients seemed less distressed, self-reported, showed a better sense of well-being. And then PCPs observed patients, more than 73%, showing better self-management for themselves. Last piece that's really kind of key to highlight overall, one of the metrics that was showed is for every dollar that's been invested in a program like this, there's a return of investment of about $6.50. And that is shown through, hospital admissions, readmission reduction, as well as ED visit reduction. And so there's kind of two sides to this. There's the reduced spend, and then now there's an increased revenue opportunity for participating in the program. And I will wrap it up by just going over all the technology pieces that really enable us to be able to implement this program in a partnership with a PCP. The goal here is really to reduce burden, not increase burden or administrative burden on a practice. And these tools really help allow us to do that. And so we have online screening tools. You could use online or hard copy. If it's hard copy, we then still score them, and it's all entered and tracked inside the registry that we provide. The registry allows for ongoing care planning, in which the full care team can provide input, and the PCP has a very easy and efficient way to see where their patients are in progress at all times. And then this last piece really addresses the patient. We talked about it's not just enough to identify, but engagement is the huge piece of what's been missing so far. And so in addition to providing telephonic and really giving the patients the opportunity to get access to care in a much easier way, we also provide televideo in the home, and then we provide apps that are available on any device that a patient may have for those that may be a little bit more tech savvy. And I'll just wrap this up with one of the quotes that we have from a physician partner that's been working with us. And one of the things she said is, "Hey, this is something I've been wanting to implement since I've been in practice for the past 20 years. And now I'm really actually getting to treat the patient the way I wanted to, assessing their physical plus their mental together, treating the whole patient." And so I will stop there, and we could open it up for questions and discussion.
All right, thanks, guys. Well, that was a wonderful presentation, and we do have a few questions that we would like to ask today. And so the first one being, let me see, let me pull these up. Who does the billing, and how does the billing work?
Okay, I will take that one. So the billing for these codes it's meant for the primary care physician to stay the quarterback of care, and in that respect, they are the billing provider. And the way we work is almost as a subcontractor to that, where we provide the psychiatric and social work services to the PCP. And so if I was to walk through how something like that may look, so a patient comes into the office, the provider gives them an assessment. The assessment's completed. If the score is high enough for them to, qualify for depression or anxiety, they are able to just refer the patient directly to the program. At that time, they're able to schedule the patient for a phone call with our care manager. Care manager follows up. Average is 60 to 90 minutes per month that is provided to a patient, and that is what's needed to drive the reimbursement. So we would provide that all of that information to the PCP kind of in a report each month, and we also, if needed, provide billing support. So they have the opportunity, of specifically for our codes, to maximize kind of revenue and efficiency. They could use our billing services to help drive just kind of clear reimbursement across payers. And so reimbursement is done on a monthly basis.
Okay, great. Second question is, you mentioned online assessments. How does that work?
Yeah, another good question, kind of operational side, so I'll take that one too. And we touched on that a little bit already. So there are two options that a patient could use: a tablet, which is a really great approach. Our assessment can be done right in the waiting room, takes a few minutes, and the results are real time. And so by the time the patient goes back into the office with their primary care physician, the physician has their scores on depression, anxiety, trauma, substance abuse, and they can talk to them real time about those results and make a referral immediately. And so that's how that works. The other approach, though, is through a hard copy assessment. Some populations just are not comfortable with doing tablets, and so we provide a hard copy assessment that's given right at intake, and that can be done pretty immediately as well. In that scenario, we collect the assessments, we still score them, and they're entered into the registry, and referral decision is made by the PCP on an ongoing basis for those.
Okay, great. And along with that, we had a question come in and says, where do you find the assessment?
I'll continue with that as well. So we provide the assessments directly. So it's a good question. Part of our assessments come from kind of our proprietary list of socio-determinant factors that we want to get a good handle on for the patient as we reach out to them. And then the rest of the questions are just clinically validated rating scales, like the PHQ-9 or GAD-7 for anxiety, and those are what we use to assess the patient.
Okay, great. Here's one that came in. ACOs are accountable for a total cost over a 12-month period. So how soon can the 6-to-1 ROI be realized?
That was a really great question. And sorry, Lindy, but all the questions seem to be operational, so I'll keep going with answering them. So there's really two means to realize revenue. And so ACOs are, as we've talked to, have kind of two things on their mind: driving cost savings and quality care, and that being able to be recorded and measured, and then receiving the incentive payment at the end of 12 months for that year. And so Mind Healthy drives that through this ongoing collaboration and the impact to outcomes that we talked about. And so we actually help with that through the reports that we do and this kind of ongoing tracking of mental health on a qualitative basis. So you have reporting there. We talked about the quality measures. And so that is a large part. If we were to look at that average patient that costs $16,000 more than the patient without mental health conditions, say you just cut that $16,000 in half through the effective care that we have. If you have a population size of 10,000 patients and you've got 10%, you can see where you could really make a big dent in your medical spend on patients with mental health conditions really quickly, to pretty significant. Then the second way that we impact that $1 to $6.50 ratio is just direct revenue. And so this is a very affordable offering for the patients, in which they only pay the copayment for the care on a monthly basis. And then there's a billing that's reimbursed directly to the physician. And we have that subcontracted rate that comes out. But there's a pretty good profit that remains for the PCP as long as each member is on the program on a monthly basis. And that drives a very real-time revenue that starts within 30 days of the patient being on on the program.
Great. Next question here, and these are in no particular order. Do you have to use the registry, or can it be the organization's electronic record?
Another good question. So a registry is required. And so if there are sub-organizations that, may have a registry, there are very few. I will say there are very few that I've seen that already have a registry. It is a requirement by CMS to have that. And that's something we provide, and it's built into the cost of the program that already for us. The last thing that I will say on the EHR and how we really try to work with each ACO is we provide documentation directly into the office's EMR. So we do our noting directly, so it makes it very simple and easy for billing. There's not multiple systems that the office has to go to. We do our documentation right within their EMR.
Okay. Next question. How does C3 Mind Healthy program help the patient deal with their local/home environment that may be contributing or causing to their behavioral health problems?
So with the follow-up, it's very similar to traditional counseling that they may be receiving or have received. It's up to the patient. We try to establish at least biweekly, but I have some patients that I'm talking with on a weekly basis or scheduling for, supportive counseling. And, it's very similar to any other type of mental health service where we go through and look at strengths, weaknesses, things going on within the family, the home environment. And, care management is there to help patients with solution-focused type therapy and finding other ways of coping in environments that maybe they can't control, and in areas that they may have identified stressors, looking for alternatives for housing and understanding what resources are available to them within those environments. And then there's a very clinical therapeutic approach with cognitive-based therapies and other types of models of mental health treatment that licensed clinical social workers, are going to be working with these patients on telehealth or telephonically.
Okay, great. Next question here. Do care managers have to have a separate care plan per patient, or are the goals on the PCP's care plan?
That's a good question. Of course, everything needs to be integrated and aligned with the medical home. And so most of the time, the goals are going to align because the screening tools that are utilized in the primary care office are identifying some of the issues that patients are dealing with. And so we sort of have a heads up to that information before we contact a patient. And then as we sort of develop the treatment plan, we're mindful of what the goals are within the PCP office so that we can help direct the patients, around those same goals, and then also have the ability to add goals as well for things that may come up in our care management issues, maybe like substance abuse issues or things that, providers may not be aware of that we can also address to help the patient reach their overall goal of managing depression, anxiety, et cetera.
Okay. So far, do your patients express satisfaction with this model versus more traditional office-based talk therapy?
I can take this one at a high level, then maybe I'll transfer it to Lindy for more, personal approach. And so at a kind of more of a numbers, statistics answer, about 60% of the patients that are referred are engaging right now. And, the response has been pretty positive in terms of this is a group that often just has been used to having quite a shortage of this type of care. And so we get a pretty quick response and turnaround in terms of patient engagement and satisfaction. And so I can say that, from a statistics number, about 60% of patients engage in the program from a warm referral And then Lindy, would you add anything to that in terms of?
I think what you find are two types of patients. You have the patients that, of course, are struggling with mental health, and they're either scared or don't know how to access services, or there's a lack of services. And so the care manager can really build rapport, build a relationship, and plant that seed and create a comfort level for patients to engage in more traditional psychiatric and counseling services, especially around the areas of like trauma, domestic violence, other types of issues that may need more in-depth specialized treatment. And then also, we have patients that have maybe already been part of, detox programs, other types of cognitive behavioral counseling programs, in-office-based therapy, and they sort of graduated beyond that, but are still experiencing everyday life stressors that the care management, or maybe physical health conditions, diabetes, other types of things that, they may not qualify or have access or need the in-office services, and this is a great way to still have supportive counseling, but it's a little more flexible and available to them, on a convenience basis where they're not having to schedule months out for traditional psychotherapy or psychiatric services.
Okay, great. And the second part of this question, and you may have already alluded to this, is other than actual symptom reduction, how do you assess patients' perceptions of behavioral health treatment?
Well,
Want to take that, Lindy, or I can take a swag at it?
you can take a swag at that one.
Yeah. So, we, as you mentioned, we have the quantitative approach, which is, just very clear, straightforward. So reducing scores on the screening tools. And then in addition to that, there's ongoing progress notes and care plans. And so Lindy and Lindy's role, or the care management team, are making ongoing assessments to the patient care. So we talked about, really providing the qualitative notes on patient care. In terms of kind of how a patient might report back, I think it was really interesting that the CAP survey for 2019, out of the 50 questions, about 10 of them were related to or directly related to mental health and behavioral health. And so there's just a huge opportunity for patients to respond in terms of their patient satisfaction.
And I think if they continue through the program, then that's sort of the answer. If they stick with it for 6 to 10 months, and we have that much documentation, then obviously they're engaged. If a patient doesn't want to engage in something, they're not going to answer the phone. They're not going to schedule a televideo type psychotherapy visit. And so far, as we get new referrals in, there's at least half or more of the patients that I contact on a weekly basis that are interested and engaged with the service immediately and for follow-up.
Okay, great. And I think we've got time for just one or two more questions here. This one is, you've outlined how your product might help PCPs connect their patients with behavioral health expertise. Is your product configured to connect behavioral health patients to PCP providers in support?
That is a really good question also, and we get that in a couple different ways. And so the first way is, hey, we go to a PCP or office, and the PCP has 50 patients that they are managing already on their own for mental health issues, and so they're doing the medication management. They may have referred them out, and they didn't, follow through with psychiatric referral. And so there's a group that has a diagnosis that the PCP refers directly to us. We do traditionally kind of go directly to the PCP for that channel or that funnel. And we don't right now go to like a behavioral health organization and add this for a supplement. That's something we could definitely consider in the future. But right now we focus really the channel and the funnel through the PCP. And I think we capture a lot of patients that are working with psychiatrists or, maybe some other mental health professional or peer support that way. And we're able to add additional support to that care.
Okay. Well, very good, guys. Well, that's all the time we have for questions for today. So thank you both so much for participating and for presenting. It was a wonderful presentation. As we conclude here, I would like to encourage you to visit the C3 Healthcare RX booth on the ACO Exhibit Hall website, as you can see here on the screen, to learn more about them and connect with their team. And this is also where the recording of today's session will be found, and the slides will be available for download. And you'll find both of those in the reference library. Lastly, if you have any specific questions for either of our speakers, you can contact them directly. Their contact information is going to be here on this last slide. Feel free to make a note of that and I guess we don't have that, but it will be made available to you. And they will be happy to follow up with you for further discussion. So thank you all for attending. I hope you found today's presentation very informative and helpful, and I hope you have a great rest of your day. Thank you so much.